Good afternoon, all. I'd like to welcome you today to our webinar titled Eating Disorders in Males. A few things to note. All participants will be muted upon entry and videos turned off. For technical assistance, please use the chat box located at the bottom of your screen. You'll receive an email in approximately 3 months requesting feedback and impact on today's presentation. For additional trainings, we ask that you visit our website within the NC Training Center at www.ncdus.org/training. We also would like to let you know that you will receive a copy of today's slides along with the evaluation immediately after this webinar has ended, and any additional references that have been shared by today's presenter. We will also have a 10-minute question and answer segment, if allowed, at the end of this presentation. Any unanswered questions will be sent via email within 1 week from today's date by the presenter. I'll go ahead and introduce today's presenter. Our presenter today is Dr. Anna Bardone-Cohn. She received her BA in Mathematics and French from Williams College and her PhD in Clinical Psychology from the University of Wisconsin-Madison. She completed her predoctoral internship at Western Psychiatric Institute and Clinic in Pittsburgh, Pennsylvania, and from there became an assistant professor of psychology at the University of Missouri-Columbia. Since July 2009, she has been on faculty in the Department of Psychology and Neuroscience at the University of North Carolina at Chapel Hill, where she is currently a Bowman and Gordon Gray Distinguished Term Professor and the Director of Clinical Psychology. Her research program on eating disorders and body image focuses on psychological and sociocultural perspectives. In particular, she has interests in perfectionism, self-concept, constructs, self-efficacy, self-esteem, contingent self-worth, social media, peers, and family. Two themes she has explored in the past couple of decades, often in conjunction with the psychological and sociocultural constructs listed above, are developing and testing a comprehensive definition of eating disordered recovery, and examining disordered eating and body image in diverse populations in terms of race, ethnicity, and gender. I will now turn things over to Dr. Anna Bardone-Cohn.
Great, thank you, Lachelle. Appreciate that. Yeah, great to be here. Glad to see folks joining, and we will just dive in. All right, so my topic, eating disorders in males. Here's just a broad sense of the goals or objectives for today's talk. So we want to talk a little bit about rates of eating disorders in males. I want to share some comparisons in terms of clinical presentations for males and females with eating disorders, and then spend some time talking about the identification, assessing, and treatment of males with eating disorders and some barriers to that. And so this is sort of was my overview of the different topics we'll be covering. I think I'll just leave it at that. So this covers the goals and objectives, and also lets us talk about a few other things related to males and eating disorders. What I do want to say before going on is just I want to acknowledge the use of the term male here. So when I'm talking about research on males, it will really be cisgender males. So these are people who identify as male and were assigned male at birth. We know much less about males and eating disorders than we know about females, and we know much less about transgender males and eating disorders. So the literature really, what I'm pulling from is for cisgender males, but I want to acknowledge that we need more research both on cisgender and transgender males. And then also when I talk about eating disorders, I'll be focusing on anorexia, bulimia, binge eating disorder, OSFED, so other specified eating disorder. I won't be talking about ARFID, so I won't cover that in this particular presentation. All right, so starting out, who develops an eating disorder? So, what image comes to mind? I'm not a I'm not a gambler, but I would put money that almost all of you thought of a female. So there is the stereotype, right, of people with eating disorders being white, upper middle class, young female. So the female part is what, again, I think I bet all of you kind of popped into your head. Now, historically, so males with eating disorders are considered very, very rare. I mean, there are points where it's sort of like they don't exist. We know now that that is not true, and we'll be moving along to talk about that. But I want us, as we move through this presentation, to think about the implications of having such a female-centric perspective on eating disorders. Because there was a thought that only women could get eating disorders, our diagnostic framework was developed around the assumption that that was a female disorder. Our assessments, what we've developed as assessments, have been focused on females, and then treatments, the development of treatments and clinical trials, often men are not present or present in very few numbers. So there are really some significant consequences of having thought for so long that eating disorders is just not a male thing. So in the late 1970s and then 1980s, we were starting to see these reports of males in specialist eating disorder clinics. And then in 1990s, there was a more systematic approach and research to examining males with eating disorders. And what we saw there is that about 5 to 10% of cases in specialist eating disorder clinics were males. So that kind of explains, I think, the 10% rule of thumb that probably a lot of you have heard of. So the idea that the ratio is about 9 to 1, females to males with eating disorders. Now, note that this information was coming from specialist clinics, and men are less likely to seek treatment, and especially less likely to seek treatment for eating disorders. So I think we all knew this was an underestimate of what was really out there, but we weren't really sure kind of what the actual, the reality was. So more recently, there's been epidemiological data that gives a better sense of, gets us closer to the reality in terms of rates of eating disorders in males. I should say that clinical, if you do look at specialist clinics, eating disorder specialist clinics, you do see close to still about the 10% generally are male. But if you now look at epidemiological data, you see a pretty different story. So of people who have anorexia nervosa or bulimia nervosa, about 25% are male. And when you look at kind of significant eating disorder behavior, so this could be things like extreme dieting and fasting and purging, about 33% of people kind of reporting those sorts of behaviors are male. And so our better new rule of thumb should probably be kind of close to a fourth and to a third of people with eating disorders are male. There is some evidence that the rates of eating disorders may be increasing more quickly for men than for women. There certainly has been documentation of just a huge increase in hospitalization. So for example, from 2010 to 2016, in a study in the UK, there was a 70% increase in admissions for men with eating disorders. Now, whenever you see those increased numbers, the question is, are there actually more of them, or they're just more being recognized? And usually the answer is a bit of both. So we definitely are seeing, again, these higher numbers. In terms of lifetime prevalence for males, the ordering I put here is just like, where do we see the highest lifetime prevalence, the lowest? So the highest is an OSFED or EDNOS, so this kind of called subclinical categories, not quite meeting criteria. And then next is binge eating disorder, next bulimia nervosa, and next anorexia nervosa. And I'll give you sort of a range of prevalence rates. And I think this is useful to know. For me, the big take-home message is the 25%, right? Like that's, when we think about people with eating disorders, a good quarter or more are male. So anyhow, in terms of lifetime prevalence rates for the OSFED EDNOS, less information on that, but there's some support for maybe about 4% of men in their lifetime will meet criteria for OSFED or EDNOS. EDNOS is the older form in DSM-4. In terms of binge eating disorder, a common range that is seen is 1 to 3%. So again, for men in their lifetime, 1 to 3% would develop binge eating disorder. Bulimia, the range seems to be about from 0.5 to 1.5%. And for anorexia, the range is often reported as between 0.1 and 0.3%. What's important to know is that, well, one thing that's important to know is that they're comparable levels of distress and impairment for males and females. So even though, more women still have eating disorders than males, they are equally distressed, generally equally kind of, quality of life impairments. And however, and this is a theme we'll keep returning to, men are less likely to get help and seek treatment. So similar levels of distress and impairment, but they're not getting the help at the same level. So what I'm going to do now is I'm going to go through and talk about anorexia, bulimia, and binge eating disorder. Just put up the diagnostic criteria from DSM-5, go through it pretty quickly, but then talk about some nuanced differences when we think about men or males. So anorexia nervosa is characterized by restricted dietary intake, and that results in a very low weight, intense fear of gaining weight or becoming fat, or behavior that interferes with weight gain when someone is at a low weight, and then disturbed body perception, self-evaluation overly due to weight or shape, or persistent lack of recognition of the seriousness of low weight. Now, most of you all know that the criteria, there's some changes in it, and the big change relevant to studying eating disorders in males is that in the DSM-4, there was a criterion related to amenorrhea. So there was a requirement that to meet criteria, you would have at least 3 months with an absent menstrual period. That's a great example of how a female-centric approach to eating disorders resulted in a diagnostic criterion only being relevant to females. That is not included in the DSM-5, and I think was just kind of ignored prior, but the fact that it was sort of there, kind of indoctrinated in the diagnostic framework, I think tells us a bit about how we've been thinking about eating disorders for quite a long time. All right, kind of unpacking this a little bit, a couple of comments I want to make in terms of that symptom picture in males. So men with anorexia, absolutely dietary restriction, but they may have a different motivation. Now, for some, it really might just be losing weight and a sense of control related to that. But for others, it's not so much thinness per se, than leanness. And we will be coming back to this when we talk about kind of what men might strive for in terms of a body ideal. So by kind of reducing your body fat, that can help increase the visibility of musculature. And so that might be really the motivation for dietary restraint, and maybe less common for women. Generally, there are lower levels of weight concern reported by men than women. And this is broadly, not just in the context of anorexia. The other thing for men and weight is that whereas for women, generally, there's a desire to be lower weight, generally. For men, it's kind of like you can be too heavy or too small. You can weigh too much or too little. And so often for men, again, this is stepping outside from anorexia per se, but there's this inverted U, and the higher end and the lower end of BMI is associated with a poor subjective well-being and more body dissatisfaction. There's generally similar levels of shape concern for men and women with anorexia and kind of broadly, but what parts of your body shape are a little different. So men tend to be more focused on like having broad shoulders and a narrow hips and waist. That captures what's called a mesomorph body type. And in terms of the stomach, there's an item on the eating disorder examination questionnaire about wanting a flat stomach. Well, men were more likely to say, I want a six-pack. Like, I don't really want a flat stomach. I want a super muscular toned stomach. And then excessive exercise. This is something that is a common feature, not only for anorexia, but for other eating disorders. And it's also just a common feature as part of maybe a potentially disordered eating presentation. This may be more central to anorexia for men than for women. Some evidence for that. Also some evidence that excessive exercise for men may be more functionally connected to affect regulation. And if that's the case, that should make it even harder for this to be a behavior that changes for men, because not only is it kind of getting them to where they want in terms of maybe their body and their musculature, but it does something for them in terms of affect regulation. So that poses additional challenges, I think, in working with men. Driven excessive exercise in population surveys are, show generally not too many gender differences. So they might have, one study looked at about 3 to 4% for both men and women. And there's some evidence that this might be elevated among youth. So kind of young men might especially be engaged in excessive exercise. All right, so then bulimia nervosa, so recurrent episodes of binge eating and inappropriate compensatory behaviors. Binge eating refers to eating an objectively large amount of food in a discrete period of time with a sense of loss of control. And then the compensatory behaviors are these behaviors try to undo or counter the binge. And these include things like purging behaviors like vomiting and laxative use and diuretics, and then also non-purging behaviors like fasting or excessive exercise. And then a couple comments here. So for binge, we talk about an objectively large amount. Well, what that looks like might differ from males. So men might have different perceptions of what counts as a large amount. I can tell you that in research, when we're trying to assess people with binge eating, there are guidelines that can be followed that say this is what constitutes large amount of like pizza or large amount of cookies, things like that. And we've had men say that doesn't feel like large to me, and assessors also say I don't know, for this guy I know that would not be a large amount. So that gets a little messy, a little kind of complicated. There is some evidence that men might be a little less distressed about binge eating than women, but there's a similar impairment of psychosocial functioning, even absent maybe slightly lower levels of distress. And then in terms of types of compensatory behaviors, purging behaviors, so vomiting and laxative use, for example, are less likely in men, but while excessive exercise is more likely, more common for men. And then binge eating disorder. So this is looks like bulimia nervosa, but there has to be the absence of any regular compensatory behaviors. Binge eating disorder is the eating disorder diagnosis with the smallest gender disparity. Research often says that of people with binge eating disorder, about 40% are male. So that's really, again, almost even. That makes sense in part because we don't have the compensatory behaviors, which, again, the purging ones are much less common for men. And if you just focus on binge eating, so not binge eating in the context of binge eating disorder, we especially see there that there are not many gender differences. And in some cases, actually support for maybe it occurring more for men. Okay, a few other clinical presentations to talk about. One is that greater psychiatric comorbidity. So men with eating disorders are more likely to have a comorbid condition. Common comorbidities are depression, anxiety, substance use disorders. In general, they have a later age of onset for their eating disorder. They tend to have a history of being overweight or obese. Some research indicates that 40% of males with eating disorders have this history of overweight or obesity. And not unrelated, they're more likely to have an experience of weight-related teasing. Medical complications are pretty similar for males and females, but to the degree that men are often later to seeking treatment, which could mean sometimes that they're delayed seeking treatment means that they get to a more severe case, they might have more severe experiences with these sort of problems. So cardiovascular concerns, so bradycardia, really slowed down heart rate, which sometimes necessitates hospitalization for medical stabilization. Gastrointestinal concerns, delayed gastric emptying, that can result in kind of feeling bloated or constipated. Decreased bone density is another concern that men with eating disorders experience, and that can be increased risk for fractures and osteoporosis. And regarding bone density, that's another place where we see an interesting way where the female-centric approach kind of left men out of it a little bit. There had been some guidelines for the use of obtaining a DEXA scan for adolescents with anorexia to assess bone mineral content. And the guideline there was you would only use that when amenorrhea has been present for at least 6 months. Again, not relevant to males, but that was in the guidelines. And then there wasn't anything like, for males, is there a guideline? There wasn't. And then lastly, I want to say a little bit about mortality for anorexia. Anorexia nervosa is the second deadliest of the psychological disorders. And this is no different in terms of for males. It's also very concerning for males. Mortality in males with anorexia is almost 6 times higher than those in a male reference population. So it definitely is a increased risk factor there. All right, the next slide, I'm going to put a quote I saw last year, and I just, I can't remember if I was going to give, I know I was going to give this talk at that point or not, but anyhow, I saved some of these things because I think about this sort of stuff. This is a quote from Jonah Hill, and Jonah Hill is an actor. He's probably a familiar name to folks. I am spacing on his movies, but he did the 21 Jump Street movie. He's a comic actor, but also the serious stuff. I think he did The Big Short. Anyhow, so he's a guy who generally has been a heavy, he is a heavier person. And he had this quote that he put out in February of 2021 on Instagram saying, "I don't think I ever took my shirt off in a pool until I was in my mid-30s, even in front of family and friends. Probably would have happened sooner if my childhood insecurities weren't exacerbated by years of public mockery about my body by press and interviewers." I think this was in conjunction with when he had lost some weight and yeah, it was kind of, I don't know, you know, I'm not sure exactly more of the context. He said this post wasn't like a yay me or you know, kind of post, but it was, he said, for all the kids who don't take their shirts off, you know. And so that's how he put this out here. There are all these comments and people were kind of praising him for his body and for his body positivity. And then some months later, he posted this: "I know you mean well, but I kindly ask that you not comment on my body. Good or bad, I want to politely let you know it's not helpful and it doesn't feel good." And so I think this speaks to, I'm transitioning because we're going to talk about body ideals and body satisfaction, that, you know, he had a history of obesity. He probably had a lot of weight teasing, you know, didn't feel good about his body, now is in a different place, which is great. But then I think people were commenting on, "Oh, so great in body positivity." It's kind of like, let it be, right? Let's just not talk about the body. Let's just kind of be an actor and be a good human or whatever. I'm extrapolating a little bit here, but I think the point is well taken that that kind of probably for all of us, male and female, kind of having a reduced focus on the body is just better. I should be clear here. I'm in no way implying that Jonah Hill has or had an eating disorder. I have no idea. I'm only bringing this up because I want us to talk a little bit about body ideals and body dissatisfaction, and I thought it was a relevant quote. All right, so on that topic, body dissatisfaction is a robust predictor for eating disorder pathology in women, and we find that it also is very much present in men and very much a predictor of disordered eating. So if you look at studies, for example, of college-age men have found that rates of body dissatisfaction are quite high. Some ranges are like 68% to 96%, pretty consistently at least over 50%. So kind of thinking this is almost a normative experience for young men to be dissatisfied with their bodies. In terms of the weight part of body dissatisfaction, I referred to this before, it's kind of this inverted U. So kind of weighing too much or weighing too little is often a piece of the body dissatisfaction for males. And then muscularity, not being muscular enough, is a source of body dissatisfaction. In a twin study in Finland, they found that if you look at men who were ages 22 to 27, about a third of them said they were very dissatisfied with their musculature. And that's musculature generally, but especially upper body musculature. So the male body ideal really hits along these two themes: high muscularity, low in body fat. And it's that broad shoulders, narrow waist, hips body type that is especially seen as ideal. This lean muscular ideal is evident in a lot of places. We see it with male models, sports figures, action figures, video game characters. In terms of the male models, research has shown that across time, there's been an increase in the proportion of male models who are pictured without their shirts on. So, you know, able to really focus on how musculature, you know, how muscles, how their high musculature in their chest. So that's been a change that has happened. And so really boys and men are being exposed to these ideals. Here's some examples. If you just look at kind of, you know, male models, and you've got these like bare chested, like unreasonably, right, kind of musculature. And also I should acknowledge that there is, there are filters, there's all sorts of things. So what we're seeing here is not probably exactly real, but the message is this is what's supposed to be attractive, for men. Here's an athlete, Cristiano Ronaldo, and then here's a video game character. So again, we're seeing a lot of muscle, right? That's kind of the main message there. In terms of action figures, there was a study in 1999 or published in 1999 that looked at the evolution of male action figures. And so here's what they found. They found that things changed, right? On the upper right, you're seeing GI Joes, and you're seeing across time, they had more muscles and more well-defined musculature. So if you look at kind of like the chest area, there's just a couple of lines. The guy on the left and the far right, there's a lot of lines, a lot of kind of definition. And they also looked at things like Luke Skywalker and Han Solo, where you saw a really big change in how these action figures were presented. Another study published in 2006 did a slightly different approach, but they looked at also at action figures like, Batman and Spider-Man, and they found the same thing, just, big increase in musculature. This study was over the past 30 years. The other study with Batman and Superman and Spider-Man was over the last 25 years. But what they found is if you scaled the dimensions of these action figures to like an average size man, they're either just impossible or only possible with steroids. And so again, the images we're seeing here are things that are not that realistic and super musculature. All right, so I want to elaborate a little bit on this and talk about kind of some of the implications. So appearance ideals are transmitted through social agents. And so we've already talked a little bit about media, but family, peers, romantic partners. And here's the way some of these things kind of happen. We know that perceived messages from parents and peers, predicted use of weight loss and muscle building strategies in adolescent males. There can also be modeling going on there, so that if you see a parent or a peer doing certain behaviors, you kind of buy into them and might do them as well. But you might also hear that you should build more muscle or you should kind of lose weight. So those messages are heard and acted upon by young males. Experimental studies have shown that brief exposure to the male body ideal in the media causes body dissatisfaction and negative affect. So that's been well established as well. A little bit more on perceived pressures. Media pressures seem to be especially consistently associated with body dissatisfaction for males. And this is even after controlling for their body mass index or how much they kind of buy into the athletic ideal or their experiences of weight-related teasing. So, I mention this because I think sometimes the thought is that, oh, media, we aren't affected by the media and men certainly aren't. Well, no, apparently they do have they can be affected by it, and it can be obviously very concerning. Appearance pressures contribute to internalization of body ideals. And what I mean by internalization is kind of buying into or endorsing social ideals as a personal standard. And so if you feel like, a pressure to look a certain way and to be more muscular, and you internalize that, you're saying like, I need to be more muscular, let's go, let me, take action. Pressures also contribute to appearance comparison. So comparing to others in terms of, body musculature, for example, which for most cases people will, if you look in the media, you'll say, well, I'm not as muscular, so then I'm body dissatisfied, and then you might engage in some behaviors to change that. Now, there are some moderators. So kind of to add a little complexity to this, we see that there's an increased risk for body dissatisfaction and disordered eating from social cultural messages like media and messages, especially for males who either strongly identify with those media figures or for those who have low self-esteem and negative affect. So for example, regarding the last point there, we find that males with low self-esteem who perceive appearance pressures, who feel like they do need to look a certain way, they are especially more likely to engage in behaviors to change their body compared to men or boys who have high self-esteem. So again, high self-esteem is low protective. Low self-esteem means more likely you might kind of take action based on social cultural messages you're getting. And the last point I want to make on this slide is that, guys are kind of in a bind here because they are seeing this increasingly unattainable ideal. They're having perceived pressure, certainly, that you should meet that ideal. And to do that, you would have to do something, because very few people look like those images that we saw. And yet males at the same time are not supposed to care too much about appearance. That's not a very masculine thing to really kind of buy into and take time and show that you care about what you look like. There's certainly exceptions to that. So the idea of kind of metrosexuals who would be very focused on grooming and appearance and such. But for most males, the message is more like, no, that's not like a male thing to do. And that might contribute to males kind of suffering in silence, because if you're not supposed to focus on what you look like, why would you reveal that you have body image concerns, to others? So I think men are kind of, again, in this bind of being sort of having to be mindful about this and take action and feel unconcerned if you don't care. All right, I'm going to switch gears to talk about something specific about body ideals and body dissatisfaction. That is muscularity. So, and I should say this to be clear, I'm going to talk about muscularity and drive for muscularity. Drive for thinness is definitely a piece of what males can experience, but the drive for muscularity has been understudied, and it's something that is very relevant to males. So we know that there are generally a great desire for muscularity. 90% of college-age American men say they want to be more muscular. In one study of college males, more than half of them identified as an ideal body, a body that you just could not get without steroids. We know that there is a very early age of preference for muscular bodies. As young as 6-year-olds are selecting that as the preferred ideal body. And in terms of engagement and behaviors that are motivated by these muscularity goals, research shows that more than 90% of adolescent males exercise mainly to increase musculature. There are a bunch of reasons to exercise. There's fitness, there's health, there's social reasons, there's lots of other reasons. But over 90% say like the main reason is I want to be more muscular. More than 2/3 of adolescent males alter their diet for greater muscularity, and up to 10% report using muscle enhancing substances, including things like anabolic steroids. And anabolic steroids provide swift changes to muscle mass, initially few side effects, but with long-term use, many concerning psychological and physical side effects, including depression, suicidal ideation. So this is what's kind of happening with muscularity in terms of there's an interest, there's a drive, there are behaviors occurring toward it. And so this term has been coined, muscularity-oriented disordered eating, or MODE. And this is trying to better capture males' experience beyond kind of what we usually think about for disordered eating. So muscularity-oriented disordered eating is two-dimensional. So one dimension is this drive for muscularity, so increase in muscle mass. How do you do that? Caloric surplus. So eat more beyond your kind of maintenance level. There's a focus on protein consumption, often very rigid rules. And there's a drive for leanness. So that's trying to reduce body adiposity, reduce body fat. And how do you do that? Caloric deficit, dietary restriction, eat less than your maintenance level. And the combination is important because you build the muscle mass, that gets you your musculature, and by then also striving for leanness, you're going to reduce your body fat, and as has been mentioned, that makes the musculature more visible. So this is sometimes called the bulk and cut cycle, these alternating eating patterns, and they are associated, this kind of eating pattern is associated with comparable levels of distress and dysfunction as weight control behaviors in women. And I should clarify that, that this disordered eating, or emphasize for this disordered eating, these are often really kind of rigid approaches and can cause a lot of impairment in terms of, for example, not going out to restaurants because you can't, assess the macronutrient content for something, or missing out on other things because of needing to exercise. So here's some sample behaviors in MODE, muscularity-oriented disordered eating. Just go through these quickly. The first main set are eating stuff, and the others I put in there, even though they're not eating per se. So overconsumption of protein-based foods, reducing fats and carbohydrates, rigid tracking of macronutrients. So they might be kind of recording it, like in a spreadsheet and measuring it. Frequent eating, so often like every 2 to 3 hours. People who are kind of entrenched in this might feel very distressed if they can't eat with that kind of regularity. Cheat meals, this would be part of that kind of the bulking up piece, but I just throw that out as a term that people use. So these could be really large meals, could be 1,000 calories, could be multiple thousands of calories. What's interesting, so it's objectively large, and that's something that we think about when we think about binges, but there may or may not be loss of control. But what's different is that these cheat meals, these large meals, are getting people closer to their goal. In this case, I want to put muscle mass on, so I'm going to eat this large amount of food. Whereas a binge in the context of bulimia nervosa is not, viewed that way. Blending ingredients for increased caloric intake, rigid exercise regimens, use of protein supplements, and use of steroids. There is a bunch of pro-muscularity content on the web. This could be websites and blogs. And the theme is that there's an advocacy for behaviors and attitudes related to extreme pursuit of muscularity. Common themes are rigid dietary rules. So for example, like you must have this amount of protein, or here's a formula to figure it out, stick to your diet plan. Rigid exercise rules, never miss a scheduled workout, come hell or high water. And messaging about the broad benefits of muscularity. So this quote from a content analysis: when in doubt, just get really, really strong. It tends to cure most problems in training and in life. Those of you who are familiar with pro-anorexia websites or might think this sounds familiar. In fact, it is quite familiar. It's the same sort of idea. Other content that we see here often are things that information about muscle enhancing substances and the downplaying of medical risk of this kind of way of eating. I'm just putting this up here, this will go out in a handout for you all, but this is one of the conceptual models that are out there for factors that may lead to body change behaviors for males. So you'll see there's the body image dissatisfaction there. That's kind of just before the health risk behaviors, kind of as a proximal risk factor. There's societal factors, sport, bunch of other things, psychological factors. So I just put it out there to share one model that people are looking at. It's a heuristic at this point. All right, I want to say a little bit about muscle dysmorphia, muscle dysmorphia is a psychological disorder. It refers to a core belief that one is not muscular enough and the pathological pursuit of muscularity. It is a subtype of body dysmorphic disorder, but there's a lot of debate as to whether it really is better thought of as an eating disorder. My understanding is the reason it's been put into body dysmorphic disorder is the thought is that the most prominent feature is exercise and not food. But what we know is that there is the presence of muscularity-oriented disorder eating very prominent among those who have muscle dysmorphia. We also know that if you look at people, men with muscle dysmorphia and men with anorexia, there are comparable rates of dietary restraint, shape concern, and weight concern. There's also some evidence of familial aggregation of muscle dysmorphia and anorexia. And in fact, earlier on, this used to be called reverse anorexia. So a lot of people sort of seen it as an eating disorder. It's not categorized that way now, but there's a lot of support saying that we may want to consider it that way. All right, I'm going to shift gears and just talk very briefly about some different groups of males with eating disorders and then move on to assessment and treatment. So this will be pretty quick. Gay men we know are more likely than heterosexual men to have greater body dissatisfaction, more invested in appearance, have more appearance-related pressures, and that does also translate to having higher rates of eating disorders, both disordered eating and then also in particular bulimia and subclinical eating disorders. Athletes is an interesting group because there's a lot that's protective and very beneficial about playing a sport, right? And so in general, sports for adolescent males are a positive thing. It provides fitness, it provides opportunities for developing friendships, it's associated with higher self-esteem in general. But there are some sports that do put boys and men at higher risk for eating disorders. And these are sports where low weight or body fat is perceived as advantageous to the sport, so you will perform better, or that's the thought, if you are a lower weight. Sports where you need to make weight to compete, so a great example of this would be wrestling, where you need to get to a certain weight category in order to be able to compete in that category. And then aesthetic sports are sports where there is a focus on kind of visual and the appearance. And so some examples of sports that fit into at least one of those categories are wrestling, rowing, horse racing, so jockeys, gymnastics, swimming, diving, and running. Folks in these sports might gain or lose weight for perceived optimal athletic performance or for aesthetics. And in fact, sometimes what happens is this starts with that intent, and then it kind of gets out of control and then develops into, can develop into an eating disorder. Behaviors that people might engage in is over-exercising, fasting, purging, or steroid use to try to, get to where they want to be for their sport, again, appearance-wise or performance-wise. There are really important roles for coaches and athletic trainers here. So for coaches to be able to, not communicate the idea that lower weight means, better performance. The recommendation is generally, if there are some concerns, to do what you can. If it's not there, no one's medically compromised, to work with the athlete to kind of, cut back on these eating disorder behaviors instead of preventing them from participating at all. And that assumes they're medically stable. With athletic trainers, the study I'm going to report is with female collegiate athletes, but I think it's got to be, of course, just worse for males. One study found that the vast majority, so over 90%, said they had worked with an athlete with an eating disorder. Again, this is for women, but they said 27% felt confident in identifying an athlete and really, doing what they needed to. But women are more kind of expected to have eating disorders. It's less likely that trainers would be as aware or mindful or know what to do for males. So I think better training for coaches and athletic trainers would be helpful. A few things about age. A prospectively, a large general population cohort of adolescents and young adult males includes a prospective tracking of weight and shape concern and eating disorder symptoms. And what they found is that, and the age group started at 11 to 18 and then kind of moved in through young adulthood, the most common transition was adding muscularity concerns. So it's not necessarily that other things went away, but at least they started seeing that as they moved through adolescence and young adulthood. Also, they found onset and stability of product use as they moved through from kind of, I guess, tween stage to young adulthood. In terms of age and midlife, we know that eating disorders and body dissatisfaction definitely occur. They continue into middle age. Sometimes there are cases of onset in midlife. And the role of aging has been, considered to the degree that you might be comparing yourself with youth or with your younger self. You might engage in behaviors to try to counteract the aging, including trying to lose weight or trying to kind of, build up musculature. So all of those things, this kind of body nostalgia idea can sometimes motivate disordered eating behaviors. And then in terms of race ethnicity, in general, weight-related concerns and behaviors are more prevalent among men of color than white men. In a pooled data from nationally represented data set that looked at Latino, Asian, African-American, non-Latino white men, we found that basically similar rate of eating disorders. The exception they found was that Latino men tend to have higher rates of bulimia and binge eating than non-Latino white men. Also, basically the same functional impairment levels, except some evidence that maybe elevated levels for African-American men, and then lower prevalence of using mental health services for men of color with eating disorders. So even though they have comparable rates, basically, or maybe are worse off, they're less likely to actually use mental health services for help. All right, assessment. So the most often used assessments for eating disorders are not necessarily well suited for males. So for example, they sometimes focus on body parts that are less relevant to males, for example, hips and buttocks. They might focus on losing weight, not on gaining weight. They tend to not have questions about drive for muscularity, just drive for thinness, and they have generally no questions about steroids. So these current assessments are missing some men, and that also might contribute to the misconception that men don't have eating disorders because we're not capturing them because our assessment tools aren't the right tools. So we need to make sure we're assessing muscularity and body fat concerns, excessive exercise, and uses of supplements and steroids. These are just a few measures. I'm just going to have them again. You can reference them, but there is a drive for muscularity scale developed in 2004 that starts addressing this musculature, use of protein shakes in this case and supplements. More recently, the muscularity-oriented eating test. That also kind of like, again, macronutrients, caring about that. kind of the supplement piece and kind of different ways of eating and following food rules to make sure you eat enough. And then there's the Eating for Muscularity scale. This is not its complete version. The others are their complete version. This is a 27-item scale. I want to share this as well. This also is a recent measure that, again, is really, I think, answering the call, right, about doing better by men in terms of assessment. All right, in terms of treatment, treatment outcome data, studies that have looked at kind of gender non-specific treatment programs like CBT models, involving group therapy and individual therapy. When they look at inpatient treatment for anorexia, like immediate treatment, don't seem to be gender differences. Studies that have looked at long-term outcomes, so 6 to 8 years, the remission rates there you see are pretty comparable. They're not significantly different. Of note, remission is defined as not having an eating disorder, so not having anorexia, bulimia, binge eating disorder, OSFED, but it doesn't say anything beyond that, which I'll talk about a little bit when I say briefly something about recovery. In general, our pattern of findings say that there's similar outcomes to treatment for males and females. The caveat certainly is that there's minimal research, so we need to kind of look more into this and also consider, for example, is there different patterns in terms of dropouts? So more needs to be done, but as of now, seems like they're pretty similar outcomes. So there's been a question about gender-specific treatment. Should that be a thing? Should we really kind of focus on kind of a male gender treatment? And there's a qualitative study that looked at this question. It looked at men who had been treated for an eating disorder. The most supported theme was this one. We want it to be person-centered treatment rather than gender-centered. So it's not that they don't want to address gender issues. They don't want gender to be kind of the defining aspect of the treatment. Another theme was the problems with the treatment environment, pointing out that certainly in inpatient settings, very female-dominated setting, they often kind of felt like the odd one out. So that could, obviously be problematic. And especially if that makes you feel isolated, right? And another theme was adapting treatment, not doing fundamental change. And so they provided the authors kind of identified 3 main areas for adaptations: treatment materials. And so their point was, integrate us into kind of the materials there. Don't have like a separate section. Okay, and here are men with eating disorders. No, integrate depictions of men in treatment materials, and don't make it seem like, again, you're kind of a separate sort of odd one out sort of situation. In terms of treatment groups, there was more mixed feelings about that. Some people thought male only would be a good option. Some men thought that would be great. I would like that. I could talk about certain things that I don't, about like bulking and cutting weight. And then others said, I would not want that. I would not want to talk with just a male group, or I really prefer the varied opinions that I get in a mixed group. So mixed thoughts there. And also, should there be male clinicians? There wasn't any sense that there needed to be male clinicians, but there was mixed in terms of like, what should that be an option? The participants in this study had all had female clinicians. They did not report that gender was a factor, but they do think that kind of normalizing, have more of a male presence in the treatment space would be good. The general recommendation here is standard approaches, certainly addressing male-specific issues, but no big overhaul related to gender in terms of the treatment strategies, but trying to increase inclusivity of the treatment environment. There is a study, or a site in Canada that developed this designated track for men in an eating disorders unit. And they really tried to tackle stigma and isolation in particular, normalize males' unique experiences. The men on that unit also participated in broader group-based programming, so they didn't just connect to that track. They did this for about 4 years, and what they found is that there was a big increase in referrals. So knowing that there was this track did mean that more males were referred there. Also, of those who were referred, a higher percentage engaged in treatment. So all that is very encouraging. Don't know yet, they haven't reported yet, as far as I could tell, outcomes or satisfaction. So it's interesting to think about, like, there's what about the treatment could get more men in the door, but maybe once in the door, maybe actually then it doesn't matter as much aside from being more inclusive. We don't know, but this is some work that's been occurring. All right, treatment, the 2 things I'm going to mention here, these are kind of some innovations we might want to be thinking about in terms of treatment, because it's especially relevant to men. So there's no gold standard for how to address compulsive or excessive exercise. There was this thing called LEAP that's been proposed. So it's a study protocol. They haven't yet collected data as far as I understand, or maybe they're starting to collect data. But the aim is to promote healthy exercise, and they have a way that they're intending to do that. So kind of really developing treatments to tackle compulsive exercise is going to be very important for men, because that's a very prominent feature of the eating disorder. I did notice, at least in the study I read that was laying out the protocol, I didn't see any commentary on how this might be different for men. So that would be interesting to see, because there are some different types of exercise and different motivations. So I think that would be important. And then tackling comorbidity with substance use disorders. Patients with eating disorders and substance use disorders have greater emotion regulation difficulties. In this study, there was a small percentage of men in this, and they haven't done treatment implications. They haven't engaged in treatment based on this, but the implications that they talked about was, okay, if you've got this comorbidity, which is especially higher for men than women to have comorbidity with substance use disorders, then you probably want to target emotion dysregulation and kind of think about some sort of approach that's sort of transdiagnostic, like dialectical behavior therapy, that might be helpful for both eating disorder and substance use disorder and affect regulation. All right, I think I am running out of time, so I'm going to skip through a few slides and just to get to a few things. Can look at recovery thing. I have some case studies that I think are really cool. You can look at them and I'll come back to them. I just want to make sure I get to some barriers to help seeking. So we might come back to those. All right, so this is sort of a schema for how to think about barriers to help seeking. I was thinking about it as barriers to treatment, but the authors are absolutely right that no, we're talking about barriers to just getting help from anyone, right? So this is organized, as you can see, with these kind of broad contextual factors and the different levels. I'm just going to highlight a few things. So one is an individual factor as a barrier to help seeking is delayed self-recognition. So there's a sense of, well, there is a construction of eating disorders as a female thing. So men have said, I didn't know men could get eating disorders. They might also not recognize their behaviors as problematic, saying that, you know, they thought they were just trying to be healthy. And then there's shame and internalized stigma. This is sort of like a double stigma for men. There's the stigma of having a psychological disorder, compounded by the stigma of it being a disorder that is they're not supposed to have. That's supposed to be a female disorder. Delayed social recognition. So that's friends, families, coaches. Especially important is healthcare professionals, because the first contact is usually with a primary care provider. And so they need to be educated, aware. There is still a tendency to dismiss signs that would be regularly recognized as an eating disorder in females when they're seen in males. And one person I read talked about, we need to have a higher index of suspicion for eating disorders in males. And this is a broad one, but construction of masculinity, this is a big one, right? So men are expected to be self-reliant and resilient. That is counter to help seeking, right? If you're self-reliant, why would you seek help? Or that's sort of the way people might think about it. Not expected of men is to discuss their emotions, concerns, reach out for help, to have an eating disorder. And we know that gender socializations, learning these ways to be men or to be female are powerful. And men who are more tied into the male gender role are also more likely to not seek help. And so, you know, it'd be great to reframe help seeking as a way to be responsible and, you know, for self-care and strong to help men kind of be more open and able to do that. All right, last point, and then if people want, we can go over the case studies, or you will all be able to read them, or I can just answer questions. Future directions, transgender males. What we do know is that there are higher rates of eating disorders in transgender males than in cisgender males. And in some eating disorders, symptoms can really be gender confirming. So for example, a transgender boy, severe food restriction can help stave off menstruation, which would be consistent with a transition to male gender identity. We need more research on patterns of disordered eating that focus on muscularity, including more inclusive assessments. You saw some assessments coming down the pike, which is great. We need to include more inclusion of males in eating disorder research, just in general, and we need them in more epidemiological studies, because we know that men are less likely to get treatment. So clinical studies are helpful, but we need to look at kind of a bigger picture. This suggests needing maybe multi-site studies to kind of capture men. We also definitely need them more in treatment outcome research and in prevention research. We need increased awareness of healthcare professionals of eating disorders. Again, don't overlook the signs. We need some myth busting, gender nuanced psychoed to reduce stigma and isolation. So coming to this talk and spreading the word can be part of the myth busting. NEDA, National Eating Disorder Association, has done a job of kind of like talking about males and images of males kind of on their website. And then a cultural change, which I know is huge, but can we more promote a culture where men can be vulnerable, where they can disclose their problems and where they can seek help? All right, I know I want to allow some time for questions. If people do want to go over some case studies instead, that's fine too. But I have a bunch of references or folks who are interested. And then at the end, also some videos or other resources that may be of interest. All right, thanks.
Thank you so much, Dr. Bardone-Cohn. I'll go ahead and start to address some of the questions that we have. As a reminder, you will receive the full deck of slides once we've ended the webinar, and you will also receive an evaluation asking you to fill that out for us. So the first question says, has the military population been studied? I worked with multiple males that had eating disorder behaviors as a clinician for the Army.
That's a great question. I will look into that answer more. I know that they have been studied. I know also that, for example, in the VAs, there's some VAs that are kind of building in like kind of eating disorder units, not just for their women veterans, but their males. I would think that they have a higher mountain to climb because of the gender norms and the sense of, masculinity in the military, that it would be maybe triply stigmatizing, right, to report having eating disorder. So I know there's some units that are being developed. I will look into whether there's research on that.
Thank you so much, Dr. Bardone-Cohn. The next question asks, would you please repeat the issue regarding affect regulation under anorexia nervosa and excessive exercise?
Yeah, sure. So affect and maybe better so like emotion regulation. So we all need to figure out ways to regulate our emotions if we're feeling distressed, to kind of be able to bring that down and kind of not kind of let the emotion kind of rule the day. And so exercise can be something that most people use for emotion or affect regulation. So kind of feeling down in the dumps, maybe you go out for a run or a walk and it kind of helps lift your spirits. There is some research suggesting that is exercise. Men get that kind of use exercise more for that function than women. So they kind of especially get out of exercise this emotion regulation kind of function. And so the thought is that if that's true, that can make it even harder of a thing for them to change. If they use their excessive exercise as a way of kind of smoothing out their emotions, but we need to change their excessive exercise. Well, not only are we changing something that's kind of affecting their body image more the way they want it, but now we're taking away a coping strategy that they've been relying on. So this doesn't mean no exercise. This means you need to revisit it, and it just can't stay that way. So I hope that sort of helped out.
Thank you so much, Dr. Bardone-Cohn. The next question reads, you said that anorexia nervosa has the highest second mortality out of the psychiatric disorders. What is the first?
Yeah, and it's interesting. If I had given this talk, I don't know, certainly a few years ago, 5 years ago, I would have said it's the first because that's what the research showed. Opioid use disorders is now the first in terms of mortality, and anorexia is the second.
Thank you so much, Dr. Bardone-Cohn. And the next question reads, any updates about male sperm count and eating disorder?
I'll look into that too. I know that there is reduced testosterone in certainly men with anorexia, and that gets restored, but I don't know too much more about that, but I can look into that.
Thank you so much, Dr. Bardone-Cohn. The next question asks, what is your opinion about using the EDAM eating disorder assent in to screen for eating disorders, or is there a different preference for male screening?
Okay, and Michelle, could you repeat again that screener?
It's the EDAM eating disorder assent.
Okay, I am actually not familiar with that. Yeah,
Okay.
I know that this just made me think of something else, which is the EPSI, which is Kelsey Forbush helped develop it. I don't know that they use that as a screener. I think you maybe could, but I'm thinking about, I know that that has a section that really focuses more on aspects of eating disorders that may be more relevant to men. So if you could, after when you email me, kind of email me that screener, I can look into see, what others are out there, but I would think about the EPSI as something that people might use as a screener. I know they've collected data on men as well, so they're trying to get normative data so you can get a sense of when something reaches a level of concern.
Definitely. And I'll go ahead and read our last question. As a reminder, this presentation will be available 1 week from today on our training center. And the last question reads, have you found whether or not coaches or trainers also have a history of eating disorder?
Oh, that's an interesting question. I don't, they're asking good questions. I will look into that. I think that, yeah, I'm not sure. I mean, to the degree that they were athletes themselves and athletes in the sport that they're training, that they're coaching in, and it's a kind of a high risk sport, then you might find that they're kind of at an elevated level in terms of a history potentially, probably not as elevated as the athletes, because I'm thinking about kind of, they were able to move on and kind of presumably hold this position and be higher functioning and such. So maybe they're not super higher rates of that, but I would think that there'd be kind of slightly more elevated rates than, say, like, so for example, a wrestling coach, I would imagine, would have a higher rate of a likelihood of having eating disorder history than a social studies teacher at that school, given same age and both being male. So I think there probably would be a higher rate. I don't know how extreme that is, but that's an interesting point in terms of like how that can sort of be good and bad. So I think the good is if it aids with recognition, and if the coach really is fully recovered and is supportive of their athletes, and that could be really good. If they're not fully recovered and they kind of think like, well, I got through it, or I can still function, then there might be some problems in terms of pushing athletes to kind of engage in behaviors or try to make weight, and that's not very healthy. So I could see that going in a couple of directions, maybe especially related to the state of recovery of the coach. But yeah, great question.
Thank you so much again, Dr. Bardone-Cohn. We have a few questions left that were unanswered. I will be sure to get these to Dr. Bardone-Cohn, and those that she said that she will research, she will get those responses to you within a week from today. Thank you all once again for joining today's webinar. Thank you once again, Dr. Anna Bardone-Cohn, for providing such great information. I'll let you go ahead and say any last tidbits before we conclude the presentation.
Sure, Lachelle, thank you. No, it was a pleasure. It was, I want to say, I regret not being able to do the case studies. I didn't do the timing quite right, but I really encourage you to look at those. I think they have some really useful information about kind of what we see for adolescent males in terms of kind of how obesity, premorbid obesity could eventually lead to kind of anorexic type presentation or atypical anorexia, or kind of how there can be shifts to muscularity oriented disordered eating. So I did put the citation there. There's all the references, but I did indicate which article in particular that case study came from, so you can look at it, pull it up from the references and read it in full. But yeah, my pleasure, and I look forward to diving into the additional questions.
Thank you so much, everyone. Have a great weekend. Thank you.
Bye.